Good morning, everyone, and welcome to the MDONS conference. I would like to personally thank our program chairs for this meeting, the MDONS Planning Committee. Please join me in welcoming them today, and as you see them throughout the day, please say hello. We hope you enjoy these presentations and discussions that have been carefully put together by our expert speakers. Feel free to ask questions during today's presentations, and be sure to visit with exhibitors as a thank you for making this event come to life. Before we get started with the first presentation, I would like to review a few housekeeping items. In front of your table, you will find a program guide for the meeting. In this booklet, you will see the agenda, Wi-Fi information, non-CME sessions, and CME information. Because this is a hybrid meeting, we want to be as inclusive as we can to those who are tuning in virtually. If you haven't already, please go to your app store and search for Total Health Conferencing. If you have any questions during presentations, you can click on the Q&A tab within the session to submit your questions. A member from my team will be in the back of the room with a handheld mic for any questions so we can ensure you can be heard in the room and by the virtual audience. On the app, you will also be able to view the most up-to-date agenda and download the PDF slides. We also have an exhibitor bingo raffle. If you didn't pick up your sheet this morning, please get one from the registration desk. Those who complete the form will be entered into a raffle and chosen at random to win a prize. We will be announcing the winner at the end of the day. We would like to invite you all to join the networking reception at the end of the day that will include an open bar and hors d'oeuvres. It will be a great way to unwind and continue connections you made throughout the day. If you need any assistance throughout the meeting, please find a member of my team at the registration desk and we will be happy to help you. I hope you enjoy the program. I would now like to invite the MDONS Planning Committee to the stage.
Hi. Thank you. Welcome to the Metro Denver Oncology Nursing Society's conference, and thank you for getting up early and come together. And so we would like to start from introducing our board members here. And so I am Yuki Asakura. I am president. And so I'm going to pass on to Zita.
Hi, I'm Zita. I'm the treasurer of the Oncology Nursing Society.
And I'd like to say we have a few members missing, but my name is Sarah, and I am the chair of the Conference Planning Committee.
Hi, I'm Kelly. I'm one of the conference chairs.
Hi, I'm Bice. I do the program chair.
Hi, I'm Marge. I'm over health policy.
Kara Arnold, I'm on the Outreach Committee.
Mallory Badis, I'm on Outreach Committee as well.
Oh,
yeah. The what? Is it that? Yeah. And we're missing a few, so their pictures are on the screen. We just wanted to welcome you all. We are so excited about this. There's a lot of planning that goes into this meeting. And I really want to say a special thanks to Sarah because she picked out those really cool water bottles everybody has in their hand. But just a couple reminders. Yeah, I know. So a couple reminders. Next year we have our 50th annual ONS Congress in Denver. So we really want to encourage everybody to become an MDONS member and represent us at that Congress. So put it in your calendars now. I know not everybody can submit PTO at the same time, so beat your coworker to it. So monthly dinners. Every month we have a sponsored dinner. It's every third Tuesday. We do have a Facebook page now that will have that information on it as well. If you are a member, you should be receiving an email that has that information as well. So we encourage everybody to come out. We have been doing some really cool things. We have CEs at those dinners. We also have giveaways and those dinners as well. We also have a lot of scholarship opportunities that have gone unused. So we want to make sure that everybody knows that there are scholarships available not only to go to Congress for free, but there's education. If you're looking to certify this year, we also have that available as well. And then we have networking events, also outreach events such as happy hours as well. That is posted to our Facebook page. And we encourage everybody to please take a survey with the QR link that's on your table. This is really what we're going to take to heart and what we're going to put into play next year. So please fill that out. Let us know what you'd like to see from us. Our mission is really to give back to the oncology nursing community of Denver. So just remember that, and please join us for other events. Let's have a great conference.
I just want to say thank you all for coming today. I know it's been really busy out there, and thank you for being patient. We have the largest attendance this year, so that's why I took an extra minute to come in. It is my pleasure now to bring to the stage Dr. Christopher Lieu from the University of Colorado Medicine to talk about history of cancer.
Thanks, Sarah. All right, well, good morning, everybody. Thank you to the Planning Committee for the opportunity to speak to you about just a small topic today, right, the history of cancer. I'm gonna ask to do some polling here, right? So if when you see on the screen, there's a QR code, you can also just go to www.menti.com and put in that code, 8398-7853. And gonna ask for some audience participation a little bit earlier, right, in the day. So sorry to make you guys do this, but just trying to wake you up, make sure the coffee's working. Let's see if I can get this to work. Yep, okay. I'm gonna ask you some questions first, but just a couple of points, right, about this talk. I'm gonna try to get through this in about 20 minutes, which is gonna be a little bit of a miracle, but I wanna talk about where we've been, right? What is the beginning of the onset of kind of describing cancer and even treating cancer? I want to talk about where we are right now. I want to talk about where we're going. And again, I'm going to try to do that in a short amount of time. Going to ask Felix and the IT team in the back to try and switch me over to Mentimeter to see if we can get at least a first question. Okay, you guys are already on it. The Denver Nuggets did not show up in the game last night against the Timberwolves. I am concerned as a Nuggets fan, but I want to know where the run for the Denver Nuggets is going to end. So you guys get the hang of this, right? We have a lot of optimistic people here. This is good. You guys are oncology nurses, right? So it's good to have optimism. We have a good portion of the group saying that there's going to be a finals win, and then a handful of pessimists that say that Sunday is going to be a sad day for the Nuggets. Okay. Well. I'm going to ask you guys to, Felix, if you can just move it on to the next, go back to Mentimeter and go to the next slide if you would. Okay, I want to ask you guys a question. The first ever recorded description of cancer was, and your options are 2000 BC, 100 BC, 1100 AD, or 1700 AD. I asked this question of a high school that I used to give a lecture to every year before the pandemic. And I said, what was the first ever description of cancer? And they said, 1986. And I said, oh my gosh, you guys got to go way further back than that. They said, 1972. I was like, okay, we're going to be here forever. Okay. So we have a majority of the group saying 1100 AD. Okay. Well, we're going to find the answer out to that. Felix, thank you so much. You guys are awesome. Can I go back to the slides, please? Okay. So this is our case, right? And this is a real life patient. Unfortunately, the incidence of early onset colorectal cancer, as many of you know, is increasing not only in the United States but globally, but these are the patients that we're seeing in clinic. 31-year-old female, very, very healthy, shows up with blood in the stool. Colonoscopy reveals what you see on the bottom left-hand corner, and that is just this fungating mass in the rectum, and then you see that the pathology confirms that there's cancer. When we look at the CT scan and the MRI, it does confirm that there's stage 3 disease, and what I've highlighted in the circles here are what we see on the imaging. You see that there is a mass there in the rectum, and then there's also a lymph node. So this is stage 3 colorectal cancer in a very young patient who really doesn't want any treatment for this, right? It just wants to get it cut out. But how would we treat this patient typically? So how would this patient be treated in 2000 BC, 100 BC, 1970, and 2022, or we'll just say 2024 for the purposes of this talk. Okay. So again, apologize for the speed of this, but I'm going to try to bring you through 4,000 years of cancer history in just about 15 minutes, so we'll see how accurately or how good I can do that. So for those of you that said 2000 BC, you would be correct. So the first description of cancer was really in 2625 BC and was from this Egyptian Edwin Smith papyrus. Now, there is nobody in Egypt in 2000 BC named Edwin Smith. That would be really weird. But this is just a guy that bought this, paper essentially at auction, and so he got named after it. And nobody really knows who wrote this incredibly old manuscript, but essentially, people think that it was Imhotep, who's an Egyptian physician, essentially described breast cancer, described 8 cases of breast cancer. And what made this manuscript different than any other kind of medical manuscript at the time was that it wasn't really based off of magic. It was actually just based off of facts. So 8 cases of breast cancer, really no effective treatment, but they did try to treat it with something called the Egyptian fire drill, which essentially meant that they were just taking a poker and just burning it, which sounds really, really awful. Okay, so now we're in 2600 BC. How would you treat our 31-year-old female with newly diagnosed rectal cancer in 2600 BC? Felix, we can go back to Mentimeter, please. Gonna ask you guys for, and if you can advance the slide. Okay, you have 2 options in 2600 BC. You can have the Egyptian fire drill, or you can have magic. And let's just see what you guys say. All right, so kind of half and half. Part of this magic trick today will be me getting through all my slides in time so I can get Rob Lentz up here in the appropriate amount of time. Okay, so we have more people choosing magic than the Egyptian fire drill. Felix, thank you so much. We can go back to my slides. Okay, so essentially, what would this person be treated with? You know this, right? In 2000 BC, nothing, right? Our patient would have a life expectancy measured in weeks to months, right? And so what does that look like as we move forward about 2,000 years? Now, Hippocrates is considered the modern father of medicine, right? And we take the Hippocratic Oath when students graduate from medical school. He was a Greek physician, described different kinds of cancer, referring them to the Greek word carcinos, and that's where we get the name carcinoma. And the appearance of a cut surface of a solid tumor with the veins stretched out on all sides as the animal, the crab, has its feet. And so essentially what Hippocrates is defining here is angiogenesis, right? Defining the fact that these blood vessels are kind of extending out from the tumor, and so it looks like a crab, and that's where we get the name carcinos or carcinoma. What about what causes cancer? Hippocrates had the humoral theory, unbelievably incorrect, right? But that there are 4 humors that affected the health: blood, phlegm, yellow bile, and black bile, and suggested that an imbalance of these humors with an excess of black bile could cause cancer. And this is what, when you make these type of hypotheses about what causes disease, it obviously impacts the treatment that you give your patients. So Felix, we're gonna go back to Mentimeter. Sorry to keep switching you back and forth. We're gonna advance the poll by 1 question. Oh, here we go. So we have a 31-year-old female with locally advanced rectal cancer, and your options are surgery. Remember, anesthesia will not have been invented until the late 1800s. Bloodletting or leeches. You guys are really good at this. I've done this where there have been like 200 people in the room. I've gotten like 5 votes. So this is very, very impressive. Okay, so we have most people liking leeches, a couple people who just want to let the patient bleed out, and then we're gonna do surgery. Wide awake, by the way. So, okay. This is great. Felix, we can go back. Thanks so much. Okay, well, it's early in the morning. It's gonna show you a picture of a leech. Why not? So how would this patient be treated? Literally with bloodletting or leeches, and you can imagine how not effective that treatment would be. Of course, we know that there are a lot of other physicians, and now we're moving forward, again, another like 1,500 years essentially, to other doctors that were trying to determine what causes cancer and what are some of the implications. So Lusitani and Tulp, that were doctors in Holland, concluded that cancer was contagious. And this was based off the fact that multiple members in the same family were developing breast cancer. This is a hereditary cause of cancer that they were noticing, but instead of saying it's genetic, they were saying that it's infectious. Why is this a problem? It meant that every cancer hospital had to be put out into a very, very rural area where patients with cancer would then not be able to see other people. And you can imagine how damaging that was. Scottish surgeon John Hunter suggested that some cancers might be cured with surgery. He was correct. And nearly a century later, the development of anesthesia would prompt regular surgery for movable cancers that had not spread to other organs. But remember, John Hunter lived in the 1700s. Surgical anesthesia not utilized successfully until the 1800s. That's a problem. And Virchow is considered to be the modern father of modern pathology. And he hypothesized that growth could occur either in 2 ways, either by increasing the number of cells or increasing the cell size. And what he was describing was hyperplasia and hypertrophy. And these are 2 very, very accurate ways to describe cancer. increasing cell numbers, and then also the differentiation of these cells into cells that just simply cannot die. And we know, right, that cancer is a whole host of a lot of factors impacting our patients, and that is some internal factors, genetics, hormones, decreased immunity, external factors, what we put into our bodies. That includes food, processed foods, chemicals, tobacco, radiation, even viruses. And when we have normal cells that are exposed to these things, they're going to develop mutations, either from internal factors or external factors, that eventually allow a cell to learn how to not die, right? Cellular apoptosis is a critical function in our bodies, and when we lose that, you develop these cancers that can not only grow, but also invade and metastasize. What about the history of chemotherapy? Many of you in the room actually give the drugs, right, to treat our patients. So where did these cancer drugs come from? Interestingly, in 1907, there's a German chemist, Paul Ehrlich, who coined the term chemotherapy and defined it as the use of chemicals to treat disease. But interestingly, his research was mainly looking to treat syphilis. Of course, until the discovery of penicillin in the 1920s, the idea of treating any disease with any medicine was actually a pretty foreign concept. So that brings us to World War II. So at least within the last 8 minutes, I brought you from 2600 BC all the way to World War II, 1943. So we're making good progress. But this is the German bombing at Bari, Italy, and this was a port that the Allied forces used in World War II. And the thought was that this port was too far for the German bombers to reach, but they were unfortunately wrong. One of the ships that was bombed was the U.S. Liberty ship John Harvey, which was carrying a secret load of 2,000 M47A1 mustard gas bombs. The chemical warfare was not allowed in World War II. This ship should have never been at this port, right? And of course, the payload was unknown to not only, obviously, the surrounding residents, but even to the soldiers that were there. So the problem is, when you bomb a ship like this, you aerosolize all the mustard gas. And the fishermen and residents began to complain of the whiff of burnt garlic and horseradishes in the breeze. And so not only was there loss of life in the bombing, but what was really even more unfortunate was that thousands of people lost their lives after the bombing, and nobody really knew why. They just showed up to the hospital and then they were passing away. So autopsies revealed that the people, so the civilians and the soldiers, had no white blood cells in their bone marrow. And so the Chemical Warfare Service was created to study war gases, and there are two scientists, Goodman and Gilman, that were contracted to study nitrogen mustard. And so what these two scientists did was essentially do one of the first ever animal trials, a preclinical trial, and one of the first ever clinical trials. So they injected the poor rabbit with intravenous nitrogen mustard and noticed that the bone marrow essentially just disappeared, right? Became completely acellular. In 1942, they persuaded a thoracic surgeon, Gustav Linskog, to treat a 48-year-old male with lymphoma with 10 doses of IV mustard causing a remission. This was one of the first ever improvements in cancer that they had ever seen. And this really is the connection between chemical warfare and chemotherapy, some of the drugs that we use even today. They didn't publish their findings until 1946 because all this information was embargoed, because all this information came from that bombing in Bari, Italy, and it was completely embargoed by the US government. Kind of around the same time, Sidney Farber was a pediatric pathologist that decided that he was so tired of looking at cells and things under the microscope that he wanted to actually treat patients. And so he took on pediatric leukemia. And he was interested in developing a drug that could treat a disease in kids that would really kill them in about 2 to 3 months. At the same time, Lucy Wills, who was a phenomenal scientist and physician, observed that folic acid could restore normal genesis of blood in nutrient-deprived patients. What she was describing was folic acid deficiency. She would give patients folate, and they would have return of their red blood cells. So Farber thought, well, if Lucy Wills can give folate and improve red blood cells, can I give folate and then improve white blood cells, which is the problem in leukemia? But what he actually was able to do was make a horrible disease even worse. And so he actually accelerated the progression of leukemia. It's like throwing gasoline on a fire. So when this happened, they basically shunned Farber to the far reaches of the hospital and said, please don't ever do anything ever again. But he did not give up. So he thought, well, if folate made cancer worse, then maybe an anti-folate would actually make cancer better. He tried it once, couldn't get it to work. He actually got a more potent anti-folate, And amazingly, a white blood cell count in a patient started to drop to 1/6 of its peak value. And you had this kid who couldn't walk because they had such a humongous spleen and liver. Well, the belly kind of normalized, and this kid started walking around. It's something that they had never seen before. And so this was published in 1948. 10 of 16 patients had responded to aminopterin, and 5 children remained alive 4 to 6 months after diagnosis. It's pretty amazing that this was considered to be an unbelievable advance in cancer medicine by having kids live for 4 months. Now, when you look at pediatric leukemia, the cure rates are above 90%. And it's amazing how much progress has been made since 1948. And it is possible to go from the far reaches corner basement of the Cancer Center to getting your name on the Cancer Center. So this is the Dana-Farber Cancer Center. So if you ever hear about that Cancer Center in Boston, that's some of the history behind that. It's pretty amazing. I'm going to go through the next couple of slides fairly quickly. It's important to understand that, right, surgery was really pioneered, particularly at Johns Hopkins when it comes to breast cancer and mastectomy, and the discovery of x-rays, right? We have a lot of patients getting radiation therapy. Emile Grube was a 21-year-old medical student who really just used an improvised x-ray tube and then shot it at breast cancer and got a little bit of a treatment effect. He also had a lot of radiation damage to his hands, as you might imagine. Okay, so we've moved, right, from magic and leeches and bloodletting back to our Mentimeter. So we have some rudimentary chemotherapies. And so in a 31-year-old female with locally advanced rectal cancer, what do you want to treat the patient with? Surgery, 5-fluorouracil chemotherapy, or surgery and chemotherapy afterwards. 5-fluorouracil has been around since 1957. Many of you in the room continue to give 5-FU, and we certainly prescribe it a lot today. So you guys are all on top of it. You want to do surgery and chemotherapy afterwards. And I think in 1970, 1980, even 1990, this would be very, very appropriate. Okay, thanks. We'll go back to our slides. So in 1970, surgery, 1 drug, 5-fluorouracil. So where are we now? I will tell you that there are 16 plus FDA-approved drugs for metastatic colorectal cancer. Some of these, right, are chemical warfare. Some of these are chemotherapies. Many of these are biologics and targeted agents, and that's where a lot of cancer therapy has gone to. One of the major issues in cancer is this slide right here, and that is that we treat so many patients as a one-size-fits-all strategy. And we say, okay, well, this patient has colorectal cancer, so we're going to treat them as colorectal cancer. But you know this, of the 150,000 people who develop colorectal cancer in the United States this year, they're all different. They all have different tumor genetics. They all have different hereditary factors. They all have different environmental factors. So we should not be surprised if we utilize a strategy like this that only 1 patient might respond, whereas other 4 patients will have no response at all to our treatment. So can we personalize our therapy for patients with cancer? Many of you see this in our clinics now. We can start to do genomic analyses on tumors, identify a mutation, and target that mutation. So in melanoma, if about 50 to 60% of sun-exposed melanomas have a mutation in a gene called BRAF. Well, it'd be great if we had a drug that could target BRAF, which we do now. And so when you treat these patients with BRAF mutated melanoma and you give them the right drug for the right mutation, you can get a patient that has a ton of metastases all over their body. And after just 6 weeks of treatment, you can see this really impressive improvement in their disease. But some of the problem is that you want that to be a durable response. It's not just good enough to shrink a patient's tumor for a couple of months. You want that to be long-lasting. And in these early studies, remember, this is from 2011, we know that after about 4 to 6 months, unfortunately, the cancer has figured out a way against the targeted therapy. And that's why, and this is part of the problem, and that is that the pathways are so incredibly complex that we shouldn't be so naive as to just assume that we're going to hit just one target and then assume that the cancer will never figure out a way around that. There's a lot of redundant pathways here. What about immune-based therapies, right? A lot of our immune-based therapies that we give in our clinics are really just designed to turn on the immune system, because evading the immune system is one of the major hallmarks of cancer. So if you can go from a stop signal for a T cell to attack a tumor to a go signal, well, that's the basis of a lot of drugs that we use, pembrolizumab, nivolumab. And so our patient had MSI-high rectal cancer, which is a tumor that is very immunogenic. And so we do have drugs now that can turn on the immune system. So this is our last Mentimeter question for our patient with rectal cancer. If I can go back to the poll, going to ask you now, in today's day, right, with locally advanced rectal cancer, the current standard of care at least a year ago was to start with chemotherapy and radiation therapy. But who in this audience would give this patient immunotherapy to turn on the patient's immune system to be able to fight the cancer? Again, she has a subtype of colorectal cancer that is immunogenic. It's only 4% of our patient population, so it is a vast minority of our patients. But you guys really, really enthusiastic about immunotherapy. All right, so let's go back to our slides. And I'm gonna take you just through what our decision-making process was. She wanted to have kids, she wanted to avoid radiation. Very, very understandable. We started with standard of care chemotherapy. This is our one-size-fits-all treatment of FOLFOX. We treated her at a time where this was the appropriate thing to do, but the CT scan at 2 months actually revealed metastatic disease. Not only is the cancer not responding to chemotherapy, it's actually getting worse. She has stage 4 rectal cancer, so we did. Just like you guys wanted, we switched her to pembrolizumab, which is an immune therapy, and she had no side effects to the therapy, and this is what her MRI looked like. I showed you this tumor with the tumor on the left side of the rectum, and this is what her colonoscopy looked like after several months of pembrolizumab. The tumor essentially completely disappeared. We call this a clinical complete response. So at this time, she doesn't require anything. She didn't go to surgery. She just got pembrolizumab for about 1 year, and then she stopped the drug, and now she's just on active surveillance, and she's doing just fine today. And we never gave her surgery or radiation. These are my last couple of slides, right? How are we gonna get better? And that's what you're gonna hear a lot about today, right? You're gonna hear about a lot of diseases. You're gonna hear about a lot of cool therapeutics. And some of this is better immune therapies. Many of you in the room know that one of the major advances in cancer medicine is to take somebody's T cells out of their body, train it against the cancer, and then insert the T cells back into the body. This is really kind of science fiction, crazy things that are really making a big difference in blood cancers. You're gonna see this type of therapy in solid tumors. How are we gonna get better? Well, we get better by preventing cancer altogether. There's a lot of information now coming out about circulating tumor DNA. Can we draw blood and do mutation analysis on a tumor? The answer is yes. Can we draw blood and detect cancer before it actually is radiologically visible? Well, there are tests now that are trying to answer that question. Are these tests ready for prime time? I would say no, right? In terms of being able to do a one-size-fits-all test for all cancers with a blood test, but we're starting to see some data with that. So some final thoughts. You guys are part of a multidisciplinary care team. We all work together for the betterment of our patients. When we work together, our patients are always going to benefit. So thank you so much for the work that you do and for the collaborative nature I think that all cancer teams have. And we have to improve access. I'm talking about a lot of fancy drugs, CAR T studies, ctDNA. These are all things that need to be affordable. We can get better affordable drugs by just getting more effective treatments and more of those drugs out onto the market. And a lot of the clinical trials that we run at our institutions are really trying to do that. Okay? I think that's all I have for you guys. Thanks so much for listening.